Hi, good morning, everyone, and happy Friday. Welcome to the Hospital Stakeholder Engagement meeting for May, hosted by the Department of Healthcare Policy and Financing. Just as it has been for the last couple of years, this is a virtual only meeting here, meaning there is no in-person attendance. And with all of that said, let's go ahead and get started. Next slide, please. So once again, thank you for joining us and for your participation today. My name is Andrew Abalos. I'm the Facility Rates Section Manager here at the Department of Healthcare Policy and Financing. I'm joined by a handful of others from HICPUF as well, who I'll allow themselves to introduce themselves as their topics come up. We do count on these meetings to help deliver important information relating to payment policy, what the department is thinking in terms of future reforms, as well as where we're at with existing projects and claims processing issues. We definitely have some things to deliver in terms of content this meeting, but as usual, we do encourage participation amongst the attendees. So if you do have any questions, please feel free to let us know either in the chat or feel free to speak up. Next slide, please. And for those who haven't attended this meeting before, just as we always do, we record these meetings so that way we can post them online to our hospital stakeholder engagement meeting webpage when we're done. If you do participate, please make sure to speak clearly, and when asking a question or delivering comment, make sure that you give your name and your hospital as well, just so we can know who we're talking to and follow up outside of the meeting if necessary. And we do have these meetings posted generally the week following the meetings themselves. So if you plan to forward this meeting to somebody else, just keep an eye out on our webpage this coming week, and we should have all of the relevant topics and materials posted there. Along those lines, if you do have any topic ideas that you would like for us to bring to, or that you'd like to bring to future meetings, please contact Tyler Samora, whose email is listed on this slide. And then we do request that you give us at least 2 weeks notice in advance of the meeting, just to be able to prepare the content and get the potential subject matter experts into the meeting as well. Usually gives us enough time to be able to more effectively schedule. So thank you again for your participation. Let's go ahead and move on to the next slide, please. Okay, and this slide just shows us the table of our remaining engagement meetings for the year. We do always make a point to point out whenever we do have these meetings in the afternoon instead of in the mornings. That generally has to do with holiday time off and how that coincides with our medical services board meetings, which I know a lot of our hospital or attendees for these meetings like to attend as well. So just want to accommodate those that may need to make it to both meetings in a day. Okay, next slide. So this is our agenda for today's meeting. We do have a handful of things to go through. So all of that said, I think that we can go ahead and get started, and I am going to pass this off to Rain. Thank you.
Thanks, Tyler. Next slide. Hi, everyone. I'm Rain Henry, Hospital and Specialty Care Section Manager here at the department. I have the privilege of talking to you about inpatient subacute care services. So inpatient subacute care is a provision we extended during the public health emergency, at the very beginning of the public health emergency, to help address bed shortages. It's basically nursing home level of care paid at a hospital, or in a hospital, paid at a nursing home rate. We created this in response to the PHE, but also in part because we knew there were concerns about not being able to discharge members because there weren't beds available, even prior to the PHE. It gave us a chance to see how widely used this was going to be in the hospitals and if this level of care was really needed. This provision is actually, it was created in the department's emergency state plan amendment. So that was a giant state plan amendment that we did with all of our emergency provisions for CMS. It's also in emergency rules. What that basically means is that when the PHE ends, this provision automatically goes away. It's really, here's the issue. We are still hearing that there are concerns with bed shortages and trouble discharging patients to the appropriate level of care. So we want to know if we should be exploring extending this option after the public health emergency. Extending this will take a decent amount of work from the department. So we do have a manual claims process for this. Gainwell does a manual process for each claim. And then they would need to be submitted. We'd need to submit a permanent rule and get CMS SPA authority permanently in order to get this extended past public health emergency. That being said, to date, we have had so few claims for this that I can't even de-identify them to give you any of the data. So we know two things are true. There's issues discharging, and we have no one billing this option. So we really need to square those two things and find out how hospitals are or are not getting payment for these stays and why this option is not being used. So this is really one of many steps. I want to add that one of many steps we're trying to take to come up with solutions here, but we need your help. So I'm going to pass the next slide and then pass the presentation on to Andrew again.
Thank you, Rain. And so I just wanted to have an ask of our provider community here. First, we do have the breakout meeting that's going to be specifically dedicated to this topic a couple of weeks from today. I hope that that is enough notice to get the relevant people to attend. But in that meeting, we do intend to, of course, reiterate the issue and do whatever we need to engage with our stakeholders to ensure that we're having all of the right information to make or develop effective policy and dedicate the resources to. So along those lines, we do have a request in the meantime from our hospital community relating to the inpatient subacute care policy. And that is to help us identify any of the claims where the department paid for these patients. So this is the type of information listed on the claim or that we would really appreciate. So that may not be on the claim, but so really the ICN or the claim number is going to be crucial for us identifying sort of how often this is actually occurring, at least in our claim system. But any other identifying information would be useful, including the Medicaid ID of the Medicaid member and the length of stay after they should have been discharged, and of course, sort of a narrative, if possible, of why they could not be discharged. Any other information that you feel is relevant should be included as well. But of course, we are asking to send sensitive information from hospitals to the department. So please make sure that all information submitted in this way is encrypted in order to protect any member identifying information through the transmission. So we do ask once again that this is provided in advance of this May 20th breakout meeting. We do intend to review any of the information that we get prior to that meeting, but of course we understand that some of these things do take time. So anything that providers can do to help us maybe identify how these were billed or help us figure out how many payments were received or how much payment was received for these services, that would be fantastic. So just once again, plugging May 20th, 9 a.m. We do have that virtual meeting dedicated to this topic scheduled. So we do have that currently planned for about an hour. Hope it doesn't take much longer of your time than that. With that said, we are about to jump into a different topic here. So before we close out this part of the slide, is there any questions regarding the inpatient subacute care policy and anything that we've discussed so far? Okay, not hearing anything or seeing anything in the chat. I think we are free to move on, but as always, feel free to chime in if you think of something or if you just did not have time to respond to this one. So all of that said, I believe we can move on to the next slide where I will be passing off the presentation to Diana. Thank you.
Hi, everybody. I'm Diana Lamb. I'm the inpatient hospital rates analyst. Just want to make sure you guys can hear me.
I can hear you just fine, Diana.
Okay, good. Thanks. Anyway, I wanted to quickly address an issue that it's likely that you've probably noticed in the past couple of weeks. We had an inpatient claim underpayment issue that occurred. I'll kind of walk you through what happened. the affected claims were processed between 4/6/2022 and 4/28/2022. And in that process, claims that were paid a per diem rate if covered days were less than the DRG average length of stay. Let me first say this is completely an unintended change to the payment system. So this, as soon as we found out about it, we worked diligently to get this fixed. And I think by early next week, all of this should be fixed and all your payments will have been reprocessed and paid correctly. So just to give you some timeline, the system fixed was put into production on 4/29/2022. So just a couple of days ago. And mass adjustment to reprice all affected claims is actually happened. I've actually already seen what the results are. They haven't processed it completely. And they think they should get most of it done today, but if there are some left over, it may fall into early next week. But I looked at the payments that are for all the reprocessing and the claims that were in the system that was fixed on 4/29 for all future claims coming in. Everything's pricing correctly. So I think we will have fully undid that unintended change. As always, please let us know ASAP if you find any claims paying incorrectly. And I do want to put a big shout out to Denver Health and Parallon, who reached out to us early and noticed that payments were off. We really appreciate giving us a heads up, and it helped us get a resolution put in place for something that, again, was completely unintended. And just so that you know, we are working to be instituting changes to prevent this from happening again, because this is, again, unintended, and we will make sure and do our very best to make sure nothing happens like this again. If anybody has any questions about this, please put it in the chat, or I can't see if there's, I'm just quickly looking. Yeah, I don't see anything, but if you do have questions, we can answer those. Next slide, please. So just in moving on to other topics, I just wanted to let you know that the inpatient base rates will definitely be updated with the state budget action for state fiscal year 22-23. So the Medical Services Board adopted this change as of April 8th. Oops, thanks. Thanks, Tyler. And we are just basically doing what we did last year. And again, it's kind of on hold because we are in the middle of putting together a new inpatient base rate methodology. And so we put things on hold, are updating by the state budget action. We've told you this, you guys are probably tired of hearing this from me because I basically talk about this every meeting, but wanted to let you know that it's in place and definitely happening. As mentioned before, the managed care GME payment rates will remain the same for state fiscal year 22-23 as they were for 2021, since that was the last year that inpatient base rates were rebased. You can contact me if you have any questions about this. I'm happy to, share anything that isn't clear or you need more information on. Next slide, please. So the draft inpatient base rate methodology, we are, I just want to kind of give you an update. We'll just go through some of the ground rules on this. Again, this is slides you've seen before, but for demonstration purposes on anything we show, it will always, we will always maintain HIPAA compliance, and hospital claim counts under 30 will be capped at 30. Also, Medicare non-PPS hospitals equal critical access hospitals and pediatric hospitals. So we kind of had come up with a while back an order of decisions that we were pursuing, and I just wanted to give you an idea of things that we've made changes to since we last talked and what we'll be talking about next. So add-ons, adjustments to include in the methodologies. We've got a few tweaks today that we just want to walk through with you, as well as then how the budget neutrality and corridor adjustments will work. We don't have any change from that from the last time we demonstrated how it works. And then what percentage will be applied to each add-on with ceilings and floors for continuous variables. That's what we want to present in July. Next slide, please. So again, as a reminder, I know you've seen this again. We just want to make it clear that on non-PPS hospitals, we do not get a wage index or a geographic adjustment factor from CMS to apply to these hospitals. So in the cases for those hospitals, we will be applying a wage index and GAF of 1 in order to produce a result on any calculations that we do. Next slide, please. And again, the starting point for the federal, for the inpatient base rate methodology is the federal base rate. Again, it's adjusted by the wage index and GAF, and leads us to a final that we can then build on from there. The source for all this information is going to be the impact file. We've got some CMS tables, 1A through E, but it's basically we're moving away from asking information from the hospital intermediaries and going directly to the impact file. We've just had difficulty getting information, as well as they send it in PDF form, and it's very hard to work with. So we are going to be using impact file for this information. Next slide, please. So the next portion is after we've adjusted wage and GAF is that we have the Medicare IME adjustment as well as the Medicaid GME adjustment. We are reviewing those for accuracy. We're just taking a look at everything we're doing before we put it into this new model. What are the reasons why we're doing it that way? Are there better ways to do it? We're going to be going through that process and want to discuss it if there are any changes that end up coming from it during that July meeting. But I just wanted to let you know that we are reviewing everything. We're not just putting stuff in just because it was there. The other thing that's a little bit new is that the value-based purchasing adjustment is new to the model because I didn't put it in the original ones as we were talking. And to be honest, it was inadvertently left off prior versions. It was something that should have always been in there. It's and as with the other adjustments of this kind coming from Medicare, for us, it's readmission, VBP, and the HAC adjustment. They will mirror how Medicare is applying them. And again, as we've mentioned, I do know that there is an interest in making these Medicaid focused, but that's just not something we're able to take on during this process. So it's not likely to even be reviewed until after 7/1/2024. Next slide, please. So these are add-ons that we've talked about before: critical access, pediatric, low discharge, independent. We've been thinking about it, and we'd like to group that set of add-ons into mutually exclusive order of operations. So basically it would work that, for example, you're a critical access hospital. You would qualify for that add-on 1, but you would not qualify for add-ons 2, 3, and 4. Similarly, with a pediatric hospital, you're not a critical access hospital, so you would qualify for 2, but are not able to qualify for add-ons 1, 3, and 4, and on and on. So basically, you can only qualify for 1 of these add-ons. So we will be presenting more information about these, particularly, which everybody cares about, is the size of these add-ons and recommendations for that, and the ceilings and floor that would apply for continuous variables. So again, we've got a lot of stuff that we're getting ready to unfold and have good discussions with you guys about in July. Next slide, please. So we've also got some of the other add-ons that we've been talking about, and we wanted to make you aware of some changes. So the payer mix add-on is one that we do want to keep. And, you know, we've heard from a lot of hospitals and both sides about the appropriateness of profit margin add-on, operating expense add-on, and net income add-on. So a lot of hospitals had concerns about that. And we did listen, and as it is, the department would like to introduce operating margin add-on as a better measure of hospital health. So again, we want to come to the next meeting with what the size of that model, or what that add-on, well, all these add-ons would be, and what the ceilings and floors would look like for these continuous variables. Again, the quality add-on is not, it's more a placeholder. The department wants us to have that there, but we don't currently have any, we're not going to be filling that in. It's certainly not on the first rollout of the new inpatient-based rate methodology, but it may happen in the future. Next slide, please. So here's the thing that I'll be honest, we've kind of struggled with. How do we show all of you how this model works? Because everything is built on everything else. The model we've adopted includes budget neutrality factors and plus and minus 10% quarters, so that no hospital can have a difference in their rate more than 10 plus or minus 10% from year to year. So the budget neutrality factor and the corridors have a great effect on what your rate would be in addition to all the different add-ons that we've put in. So we've tried to, where we can, and I don't know whether this is something that we thought was necessary, or how you guys feel about it. That's why we're going to talk about this. But we've been masking specific hospital data. And unfortunately, that makes it really hard to show you how this model works. You know, I've been thinking about what's going to be shown is that obviously the hospital name, but then also Medicaid discharges from the prior year, as well as your hospital's overall CMI would be included in there. And so other hospitals, you would see it, but also other hospitals would see it. All the other data is public knowledge through the CMS impact file and or the HCRIS cost report database, and that's fully downloadable to anyone. So we really want to get a feel for how the hospital stakeholders feel about if we would show a fully functional model. We want to be fully transparent about how the model works. The better you understand, the better for all of us. So we want to send out a poll. We're going to try and get it put together and out next week through Constant Contact, and have you weigh in and tell us how you feel about it. Does anybody have any just quick feelings about that they're willing to share? If you don't, that's fine. We can wait. We'd obviously still be doing a poll, but I'm just wanted to throw it open in case anyone had any thoughts.
Yeah, hi, this is Elizabeth Bredenthal from Children's Hospital, Colorado. And we have been, you know, when we've been participating and collaborating with you on this, it's been hard for us to understand the impact on us without getting more specific figures. And so it seems like a model would be really helpful, but I'm wondering if it's possible to make the way that, for example, Colorado Access gives us practice specific data. Would it be possible to I know it might be extra work. Is it too much extra work? I guess I'm asking to have hospital specific data just go straight to the individual hospitals.
That is one of the things is we have 84 hospitals that we'd be building rates for. And that'd be sending them 84 different hospitals.
Yeah, I assumed it would be too heavy, but just couldn't hurt to ask. Thanks.
And you know what? And listen, I'm not saying that should be that should not be the reason. You know, the amount of work involved, I think, should be predicated on how important it is that we hold this information somehow, so that you can't see everybody else's stuff. I feel like it was sort of our own feelings that we shouldn't be showing this because it just seems like it's kind of something you don't want everybody seeing, but your rate, I mean, everybody's rate is in some way a factor of everybody else's rate because of the budget neutrality and those plus and minus 10% corridors. So it really is really difficult to try and tell you how it works and make sense to it, other than sending everybody separate information. And again, if that's something we just have to make work and is necessary for hospital stakeholders to feel comfortable with, then we're going to have to figure out a way to do that. I think what we want to do is find out, is our understanding of this correct? We do know that the best way to show you how things works is for you to see how all of it works. But again, we don't want to just brush over any concerns there would be on your own specific data. So again, we will send that poll out and ask everybody to give us their feedback on that so that we can figure out what we need to do. I honestly don't know how we would get all the data out to everybody and mask what the other portion is. But that doesn't mean that we shouldn't do it if it's a big concern. So I appreciate, Elizabeth, you jumping in there and saying something about it. So anyway, please be on the lookout next week for an email from us on that. And then I think we can go to the next page. It's basically, this has all been a big, the preview next in July is where we really should have a lot of information that I think everybody's going to be interested in seeing and has been wanting to see for a while. So if you have any questions or any concerns, please say so here, or you can contact me directly, or you can weigh in on the polling that we're going to be doing next week. I am going to put my contact information in the chat. So thank you, everybody.
Thank you, Diana. And just to add on to the poll, really it's the department's objective to add efficiency and transparency into this rate building process. In doing so, it helps us ensure that we are going to be able to meet our deadlines and then also add understanding to our provider community. In this way, if we are able to get a consensus among hospitals on how we are moving forward, then we can seek our authorities earlier, resulting in potential mass adjustments, or I guess reducing the mass adjustments that we would need to perform. So financials should be a little bit more steady through that transition. But in addition, if there are any informal reconsiderations that would result, we want to make sure that we're minimizing that opportunity as well of rates, just so that we can, again, just have a finished product, finished and polished delivered product to everyone in a timely manner. So again, be on the lookout for that poll. We do take those seriously when we're examining what kind of information that we can deliver, and that would be very helpful to know if there are any limitations around that. Okay. So I will go ahead and take care of this topic right here, and it is the announcement of an upcoming rule that we plan to present to Medical Services Board. This has to do with our current language for the EAPG peer groups. If you were around back when we were implementing EAPG back in 2016, we had announced that we were basing our rate setting off of urban and rural peer groups of hospitals. Generally, what we used were statistics from those in order to help derive rates for hospitals. So what this new rule is going to do is add more granular categories of peer groups in there. So instead of urban and rural, which were simply based off of a hospital's presence within a metropolitan statistical area, we are now adding pediatric, long-term acute care, and rehabilitation hospitals to their own peer groups. Now, the way in this impacts rates is probably for a majority of people here, it will not. However, we do intend to use the statistics derived from these peer groups for the calculation of new hospital rates and for out-of-state hospital rates as well. So our rule currently, or rule should be, is that the hospitals that are out of state, we define them either as urban or rural, and then we pay 90% of that peer group averages to those hospitals. We're adding the additional peer groups for those out of state hospitals, so that way we can better calculate base rates, which are more in alignment with those hospitals' cost profiles. So this probably doesn't impact many hospitals here, but it is certainly something to be aware of. Next slide, please. So we do have this rule to be presented to the Medical Services Board on June 10th, with the associated public rule review meeting scheduled on May 23rd. Both Tyler and myself will be present for that public rule review meeting if you have any concerns regarding this rule. But again, this is really just to, again, add granularity to our peer group categories. And this will only impact out-of-state hospital rate setting and any new hospitals rate setting. So if you do have questions or concerns around that, please feel free to reach out to Tyler and myself. We do have our emails posted at the end of the presentation, and otherwise we will have that public rule review meeting where you can feel free to drop in and add any questions or concerns that you might have, or express those. So thank you. And I think we can move on to the next slide, and that will be, yep, I'll pass this off to Tyler. Thank you.
Yeah, thanks, Andrew. So as Andrew said earlier, happy Friday, everybody. I'm just going to provide some updates on what's going on with EAPG. So we'll just get started with the module updates and I guess lack of module updates. We discussed in the January and March meetings that we have not performed any updates to the module. A big reason of this is because we have still not received CMS approval for 3.16, and we are still using EAPG version 3.10. When we do receive the approval, we will go ahead and update the grouping software to the most recent version. And just as a reminder, what these updates do, they apply the quarterly CPT and HCPCS updates. Since we're using the 3.10 still, and 3.10's weights, any codes that became effective January 1, 2022 and after won't be recognized in the system. And because of this, any claim that has one of these new codes that became effective in January this year, they'll show up in a state of suspense. The reason being that we don't want them to show up as denied. So I think that's it for this slide. So we move on to the next slide here. And we're going to be talking about the base rate calculations for EAPG. And this was a pretty big part of the transition from 3.10 to 3.16. And we discussed our approach in detail during the November 2021 stakeholder meeting. And that's on our stakeholder webpage there if you need to review it. These rates, along with both of the versions of the EAPG weights, when I say both, right, 310 and 316, both of those are posted on the outpatient hospital payment website. And as a reminder, right, all claims are still being processed using the July 1, 2021 base rates and EAPG version 310 weights. As always, if there's any questions, concerns, or comments, feel free to speak up now, throw it in the chat, or if you're more comfortable just sending an email to Andrew and myself, you can always do that as well. Next slide here. Okay, perfect. Yeah. So now we're looking at the Transition Payment Authority. And the department did receive MSB's approval through rule for the implementation, right? This is reflected in the most recent version of our Colorado rule. So as of today, though, we are still waiting for state plan approval from CMS. Just to update on where we're at kind of in that process, we responded to CMS's request for additional info. And we did that on the 22nd of April. And what this means is that, so as of the 22nd of April, this reset the 90-day clock in which CMS can respond to us with an additional request for additional information or their approval of the transition, right? Once we get this approval, we will reach out to Gainwell and have them figuratively flip the switch to load the January 1, 2022 base rates. And, after we kind of go through everything, we establish the appropriate cutoff dates, we will begin to reprocess the backlog claims through version 316. And once the rates are loaded correctly, receive the approval, any claims that were billed there, they will pay through 316. And that's going to happen while we're still reprocessing the backlog claims that we had while we were waiting for the approval. Yeah, I think that's it for this slide here. So moving on to the next one. Okay, perfect. So another reminder, right? We are still waiting CMS's approval, and any claim with the first date of service January 1, 2022 or after is going to be processed using the EAPG weights from version 310 and the base rates effective immediately prior to 1/1/22. So it's at 7/1/21 base rates. If you need a reference, either one, either the newer version, the 1/1/22 base rates, or the ones we're using currently, or the 310 weights or the 316 weights, you can find those on the outpatient hospital webpage. And the weights being used are found under the link titled October 31st, 2016, right? So those are going to be the 310 weights through EAPG. And the base rates that we're using right now, as I mentioned, they're labeled July 1, 2021, right? Any claim that's using the new CPT or HCPCS codes, effective 1/1/2022 and beyond, they may have, as we recently discovered, line level denials. And as of this week, we're speaking approximately 300 claims that were denied for this reason. And we are aware of it, and we're going to take special care to make sure that when we go through the transition that they are resubmitted and taken care of. So with the next bullet there, we're also looking into other changes that might come up within this transition. And if we see any kind of action that needs to be taken, we will reach out to you. We'll communicate with you and kind of figure out the path forward with that. If we receive approval today to go to 316, there are approximately 513,000 claims that we're looking at that would need to be reprocessed. And based on previous times, we've requested this amount of claims to be reprocessed. Gainwell's typically staggered the reprocessing over multiple weeks. A big reason for this is just to mitigate any potential overloading to the provider systems. That's something we definitely don't want to do, right? So please, please, please reach out if there are any kind of certain thresholds that we need to keep in mind. If you have any questions, comments, or concerns, don't hesitate. Please feel free to reach out to Andrew and myself. Be happy to help. I think go ahead to the next slide there. Okay. So this is a slide that we discussed in the last stakeholder meeting. And just as a quick refresher, we're going to go over it once again. And it relates to the inpatient only list. Once we begin using EAPG version 316, there's going to be a new inpatient only list that will be used. Currently, whenever an inpatient only line item's billed, it will result in a paid status with an amount of 0. It'll also have an error from the EAPG software to it. However, if there are other non-inpatient only line items, those line items will pay. With all of that in mind, all paid claims will be targeted for reprocessing after SPA approval. So saying that a different way, any claim that contains an inpatient only line item, the reprocessing will capture this. Version 310's inpatient only line items billed with the first date of service on or after January 1, 2022 that are not on the 316 list may generate non-zero payment. So there's a possibility that, some of these line items may be in a state of denial for other reasons. But if the claim itself denied, then the reprocessing effort will not pick these up. Therefore, again, it is just that our reprocessing effort won't pick them up. If there are any claims that have inpatient only line items from the 310 list that are not on the 316 list, and they're not captured in our reprocessing, we ask the providers, please rebill them. If there's any kind of questions, feel free, again, to reach out to me and Andrew, and we will be happy to kind of walk through an explanation of why a claim denied, or if we should expect repayments on the claim. Yeah, but both of our contact information is going to be at the end of the slides, and we'd be happy to help with anything that comes up within this process. But I think that's all from my topics on outpatient, if I'm not mistaken. Let me go to the next slide here. Yes, so I'm going to throw it back to Andrew. I see in the chat here. Perfect. Okay, Andrew, off to you.
All right, thank you so much, Tyler. And there was a question in the chat from Tina Bui, who stated, if we are seeing that our reimbursement for accounts in 2022 isn't matching with 310, who should we contact? So short answer, you can contact Tyler and myself about that. But just to sort of reiterate, we have had several questions that have come through regarding misaligned payments with expectation since 2022. There are a few caveats that I want to emphasize. Once again, we are still using the 310 base rates for each hospital. So if you were to go to the outpatient hospital payment webpage, which we can provide a link to in the chat, we do have the old base rates that were approved for use in July 1, 21. Those ones are still in use for the 2022 time period until we receive state plan approval. Similarly, we do have the 316 weights posted as well, but that doesn't mean that those are currently in use. We're still using that 310 methodology and the 310 weights for those 2022 claims. Lastly, and this is another problem that we have encountered, or we have had several questions about, is that we did have our drug reweight policy, which was implemented. I believe the policy goes back to 2020, June 1st, 2020. And so that essentially created 3 different tiers of drug weights that are being used for the pricing of EAPG claims on or after that date. So please keep in mind which tier list is for your facility. We do have the neutral list, the increase and the decrease. And rather than go through sort of the specifics of that policy, I do suggest that you go to the hospital stakeholder meeting webpage. We did have a handful of meetings at the beginning of 2020 where we discussed sort of the genesis of the policy and how we define hospitals that would end up belonging to those groups. So hopefully that clears up any confusion on those ones, but understanding all of that, and we can certainly walk through this as well. You can contact Tyler and myself, and we'd be happy to review any claims that you bring to the table. Definitely claims examples are very useful for us for troubleshooting those issues. Or, we can also just discuss the general policy as well and help walk you and your team through whatever steps you might need to take in order to bring your systems and the expectations of payments around them into alignment with what you eventually see from our interchange claims processing system. So all of that said, I can go ahead and move on to the EAPG carve-out project, which is our last topic that we have for today's meeting. So as you recall, we have discussed this in many previous meetings. This was part of an effort where we had, towards the beginning of implementation of EAPGs, heard feedback from hospitals that the payments of drugs were inadequate through the EAPG system. A lot of this continued through our version 310 implementation of EAPG, and the solution that the department proposed for the long term was using the average acquisition cost or a percentage of in order to reimburse these drugs. A large component of that effort was the surveying of hospitals for their drug costs, which many hospitals participated in. Thank you very much for doing so. And essentially that was feeding into our payment models on how this reimbursement model would be different than simply reimbursing drugs through EAPG. So just going through a little bit more history here. Since our implementation of EAPGs and recognizing this problem, we did have a few policy changes that have taken into effect. One of them is still waiting to be implemented, but those 3 are the 340B discount modifier. We had initially, the first of those was the 340B modifier. That changed the modifier discount from 50% to 80%. In other words, we were only reducing payment to claims or drugs that are billed with the UD modifier by 20% after this policy was implemented, as opposed to 50%, which was our original EAPG implemented percentage. So that saw an increase in drug payments to hospitals. Just as I mentioned at the top of the slide too, the EAPG drug reweight was implemented back June 1, 2020. That sort of helped rebalance our drug payments to add additional payments to those hospitals that are simply don't have the purchasing power of a lot of our urban hospitals in the area, and was able to increase payment to those hospitals as well. So that is, again, where those 3 tiers of drug weights are being used. Similarly, we do have the specialty drug carve-out that was implemented, which acknowledges that EAPGs does not adequately reimburse, and sort of the velocity at which we can make changes to it cannot adequately reimburse for some really specialty drugs. I don't know, these are characteristics of them, but they are not used very often, and they are extremely high cost. So we do have a policy where we have carve-outs for a handful of drugs. I definitely suggest, if you're unaware of this policy, to review Appendix Z for the list of drugs. And this conversation dates back to 2018. If you need more information on the genesis of such policy, please feel free to reach out. We might have some information in our engagement meeting, but At the moment, I don't have the exact meetings where we discuss this, and would need to do a little bit of digging. But all of that said, we do have our last drug payment change that I wanted to bring about or mention here is that the version 316 does add additional tiers to the current drug EAPG set between versions of EAPGs. So in other words, 3M has understood that the model under 310 was inadequate for the variation in drugs and drug costs and how changes in costs have occurred over time. So since 310, they have released the annual changes to their EAPG versions, and those have gradually incorporated many of those changes. So they include those high cost drugs that were more recently approved. They've adjusted the drug weights to account for the increasing costs or, in some cases, decreasing costs of drugs and reappropriated HCPCS codes belonging to those drugs into different categories accordingly. So all of that said, 3M obviously has been paying attention to this issue as well. So when we do have the 316 go ahead for implementation from CMS, we will start to see different payments for those drugs as well. So all of that said, please move on to the next slide. We definitely appreciate all of the effort from our hospitals and the participation in the drug carve-out project. However, we have, as a department, made the decision to suspend work on this project indefinitely. There have been a lot of changes that have occurred, which we feel have addressed some of the core issues that we've been hearing about since our implementation of EAPGs. Further, sort of the feedback that we have requested from hospitals throughout these meetings has resulted in us understanding that there is definitely an administratively burdensome aspect to it. Maintaining the average acquisition cost methodology would require regular surveying of hospitals for their drug costs. And that information does have to be thorough. We do have to work with a contractor in order to collect that information and of course develop the statistics that they need to in order to accurately calculate average acquisition cost. And of course, we do have to integrate that into our payment modeling as well through EAPG. So understanding that there are many costs and there's administrative burdens on both ends, we do want to free up those resources to work on other issues as they might pertain to EAPGs. And we are certainly open to further modifications as they relate to drugs if necessary. So along those lines, just some more things to keep in mind over the drug carve-out policy and our decision to suspend it indefinitely is that the budget neutrality aspect was something that we would still have to work with in a couple of different ways. One of the ways that we would have to accommodate a carve out of drugs was recognizing that drugs are currently paid through EAPGs and in a couple of ways. Some drugs will always pay depending on their cost and frequency. Others could be packaged. In other words, packaging is intended to say this drug cost or the service cost is incorporated into a more resource intensive cost describing the set of services that would occur during an outpatient visit. What I'm getting at here is that in removing drugs from the EAPG methodology, we were seeing an increase to the expenditures to the department. And to accommodate that, we would have to lower the EAPG weights in other ways, which could potentially result in certain hospitals being disproportionately harmed while others are disproportionately benefited from this project. So recognizing that this carve out would essentially just be shifting money, perhaps unnecessarily, between services and between hospitals, we were finding it very difficult to continue to justify to leadership and also understanding the administrative burdens required. It became more difficult to justify to hospitals as well. So all of that said, we are still open to this conversation and we definitely want to continue talking about it if it's necessary. But until we get to a point where we can solidify action, whether to continue this project or to completely abandon it, we are just going to leave it off of our future stakeholder engagement meetings. So I understand that there is a lot there. I'd be happy to field any questions around that or any concerns. And again, this isn't the complete end of the project. This is more so us pausing it to focus on other things. So if this remains a concern, we can certainly take that feedback into account as we assess recontinuing it. So all of that said, are there any questions on this slide? Okay, I am not hearing anything or seeing anything. Oh, thank you so much. Kevin writes, thank you for the thoughtful process on this. This makes sense. And yeah, like I said, if you do have any concerns, this isn't the only opportunity you have to voice them. We certainly are receptive to having these conversations outside of these meetings as well. So all of that said, we can move on to the next slide. And then this is where we begin to close out the meeting. So if you do have any questions or comments or suggestion solutions that you want to bring to the table, then now would be a good time to do so. Otherwise, we will just keep this open for a few minutes or about a minute, see if there's anything that people bring up. All right, and again, not hearing anything or seeing anything in the chat, I think we can go ahead and move on to closing this meeting out for today. If you want to move on to the last slide, Tyler. Once again, we have our contact information available. Please reach out if you do have any questions or concerns about anything brought up in these meetings, future topics for the next set of meetings that we have throughout this year. And yes, thank you once again for all of your participation today. We look forward to working with you in July, and don't hesitate to reach out in the meantime. Thank you so much.